Değerli meslektaşlarım, iyi akşamlar diliyorum. Bu yağmurlu yaz gününde hepiniz hoş geldiniz. Bu ürogenital sendromla ilgili webinarlarımızın sonuncusu ve mevsimin sonuncusu. Önce biliyorsunuz genital problemleri tartıştık. Sonra üriner problemleri tartıştık. Bugün de yine alanında çok ünlü ve tanınmış, yıllarca bu konuyla çalışan Profesör Nappi ile seksüel disfonksiyon konusunu tartışacağız hep beraber. Onun için bu lafı fazla uzatmadan bu tartışmada bütün ekiple birlikteyiz neredeyse. Sevgili Tamer arkadaşımla birlikte bu oturumu yöneteceğiz. Sonunda Erdoğan hocam oturumu ve sezonu kapatacak. Ve bu oturumla birlikte bu sezonda son konuşmamızı, son webinarımızı yapmış olacağız. Bu webinar serisini Tamer arkadaşımla beraber düzenledik ve zannediyorum çok yararlı oldu. Özellikle bizim menopoz sonrası ve orta yaş kadınlarının en çok ilgilendiği konuyu hep birlikte ele aldık, parça parça değerlendirdik. Onun için Tamer hocama da ayrıca çok teşekkür ederim bu yabancı misafirleri davet ettikleri için. O bakımdan ben sözü Tamer hocama bırakıp Sayın Nappi'yi takdim etmesi için oturumu başlatmak istiyorum. Teşekkür ederim.
Sezai hocam teşekkür ederim. Kısaca Rossella Nappi'yi ben sizlere tanıtmak istiyorum. Kendisi çok ünlü bir hoca. İtalya Pavia Üniversitesi'nin hocası. Özellikle reprodüktif tıp ve jinekolojik endokrinoloji ve menopozda birikmiş yayınları var. Özel ilgi alanı psikoneuroendokrinoloji, kadın üreme sisteminde psikoneuroendokrinoloji ve seksüel sağlıkla ilgileniyor. Kendisinin 300'den fazla peer review dergilerde makalesi var ve Google Scholarship'te HF indeksi 69, 16.000'den fazla sitasyonu var. Çok iyi bir konuşmacı, özellikle de kontrasepsiyon, menopoz ve kadın seksüel disfonksiyonları üzerine. Kendisi International Society for the Study of Women's Sexual Health geçmiş dönem başkanı. Şu anda da İtalya Psychosomatic Obstetrics and Gynecology'nin de başkanı şu anda kendisi. Ve International Society of Gynecological Endocrinology'nin Advisory Board'unda ve şu anda da Dünya Menopoz Cemiyeti'nin, International Menopause Society'nin genel sekreteri kendisi. Ve ben özellikle şu iki şeyi söylemek istiyorum ki Closer ve Viva çalışmalarının da hem yöneticisi hem içinde bulunmuş, aktif olarak çalışmış, çok önemli. Biliyorsunuz Closer Clarifying Vaginal Atrophy Impact on Sex and Relationship çok önemli bir anket sonuçlarını bize verdi bu konuda. Bir de Viva Vaginal Health Insight, Views and Attitude. Bunun da aynı zamanda yöneticisi, her şeyi ve ben daha fazla sözü bırakmadan Sayın Rossella Nappi'ye sözü veriyorum.
Good evening, ladies and gentlemen. It's a pleasure and honor to be with you tonight. And I thank my dear friend from the Turkish Menopause Society for this kind invitation. For the next 40 minutes or so, I will try to revise the topic of female sexual dysfunction, and we will focus our attention, first of all, on pathophysiology. Here, the financial relationship disclosure. We have worked with almost every company, and I would like to start saying that I thank you very much for selecting the topic of sexual well-being at menopause, because this is a very important issue. We know that positive sexual function can enhance personal and relationship quality, improve longevity, and enhance quality of life. So we really need to be very proactive in the office to address the two main problems that menopausal women display and bring to our attention. The first one is vulvovaginal atrophy, GSM as we name nowadays, and we will focus also on other dimensions of the sexual response, in particular low desire, arousal, and even orgasmic dysfunction. So it's our duty to facilitate the dialogue with patients in order to start an appropriate treatment. It's absolutely true that sexual symptoms associated with distress, what we name a female sexual dysfunction, may occur at any time in a woman's life, but there is no doubt that at menopause, these symptoms become extremely relevant in women's life, and women, they report distress more or less in 15% of the cases. We will see, however, that the symptom is there in a higher percentage of women. But sometimes women, they just do not realize how much they are distressed. So this is the reason why we have to help them. There are many factors out there that can affect menopausal sexual well-being. For sure, biological factors, we will focus our attention on hormones, of course, but there are also other aspects that relate to general health, the use of some kind of drug, and also we will see the aging process that probably has to do as well with hormones. But there are also psychological factors that can change in different areas of the world, so the body image, the mood, the self-esteem, depends on many other factors, relational factors and sociocultural factors. So it's very important to put sexuality in the context of the relationship, in the context of the culture and the society. We know since many, many years from this very elegant longitudinal study that was published more or less 20 years ago, that is absolutely normal to observe a decline in sexual function and sexual activity across the menopause. The two main symptoms, as I told you already, they are low desire and increase in dyspareunia, but there is also a progressive decline in sexual responsiveness that are related as well to the partner, in particular partner health and sexual problems, because we have always to think about the couple, but also related to feeling for partners. So intimacy, other aspects that has nothing to do with the biological factor. It's very important to keep in mind that when we face women at menopause, we have to consider how these women, they were before the menopause, not only in terms of physical and mental health, but especially how was sexual activity before the menopause. So this is the reason why my suggestion in practice is always to start discussing the sexual topic anytime we have the opportunity, when we counsel about contraception, when we counsel about the pregnancy, but especially after the age of 40. The endocrine factor is the very, very important. We study this a lot because we know that hormones, they drive all the different aspects that are involved in the sexual response. Endocrine milieu can modulate neurovascular substrate, neuromuscular circuitries, and the general sense of well-being. And they may affect in different ways desire, arousal, and orgasm. At the central nervous system level, we know that all the three major sex theories, they play a role. estrogen have been described as permitting hormones, meaning that they help the brain to set a light on in terms of being responsive to what? To the desire that is driven by testosterone, that may be considered the initiating hormone of the sexual response in the brain. We know as well that progesterone during the life of women can modulate the receptivity before menstruation, usually, especially when we suffer from premenstrual syndrome. We have data out there suggesting that women, they may be less responsive. But for sure, estrogen and testosterone are the hormones that have been studied most. And we know that these hormones prime the brain to be selectively responsive to sexual incentives, creating a neurochemical state that is more likely to induce the sexual response. And more or less all the neurotransmitters are involved. We know that it's very important to have the right balance between pro-sexual neurotransmitters such as dopamine and noradrenaline and anti-sexual neurotransmitters. They are more serotonin and GABA. And other neuropeptides and neuromodulators are involved. We don't have so much time to go into details. But it's very important to consider as well that even the genital, they are strongly responsive to estrogen, testosterone, and progesterone. And we will see during my talk that their presence is essential for sensation, vasocongestion, lubrication, and even to the formation of the orgasmic platform. And they act on the tissue directly, but also balancing a lot of neurotransmitters. They are released in the peripheral nervous system, and they are more or less the same of the neurotransmitters we have in the brain. But keep in mind that also some other neuromodulators and factors are involved, exactly as it was described in the male sexual response. Nitric oxide, prostaglandin, and other peptides such as vasointestinal peptide that is strongly related to the estrogen milieu, and neuropeptide Y, which is strongly related to the androgen milieu. So at the end of the day, what will happen across the transition to pre-menopausal and perimenopausal women? Nowadays, we should look at this topic of sexual medicine in the menopause, thinking about that some symptoms, they may be related to the decline of estradiol production, we know so well, but also we have to keep in mind that even androgen contribute overall to the climacteric syndrome, and in particular to some sexual symptoms. However, we have to consider that androgens, they don't go down with the menopause. They go down with age, because it has been described very well that a woman, when she is in her 40s, she has 50% less of the androgen that she had when she was a younger woman around 20. And if you go on and you reach the age of 60, you will have half of the androgen you had at the age of 40. So we have to consider that there is a continuum in the decline of androgen that can play a role in the clinical expression of sexual symptoms in women. And then we have the stop of the estradiol production across the transition. Another very important point that we have to consider when we counsel our patient is that different sexual symptoms, they may be comorbid. This is one of my early studies. I just present to you just to confirm that we have studied this topic since many, many years, in which, as you can see, the most common symptom that women report usually is vaginal dryness, but this symptom is comorbid with also other aspects: low desire, poor orgasm, and dyspareunia. So we really need to understand which is the leader symptom for our patient. We will see this is important because with sexual function in the menopause is usually a vicious circle. We know also that sexual dysfunction in the office is more relevant if women, they have some climacteric symptoms, especially negative emotional feeling, poor physical health, and of course other urinary problems such as involuntary loss of urine and recurrent vaginal infection. So if you think about 20 years ago, we have discussed the genitourinary syndrome of menopause. It's not only dryness, it's not only low libido, it's also other aspects that occur in the pelvic floor. We have also studied the different component of sexual response across the transition. This is a cross-sectional study, so it's not so valuable as a longitudinal one, but I'm reporting this study just to tell you that when we focus our attention on early postmenopause, in which you see that we have really the majority of the dimension of the sexual response impaired. You see here we use the very famous female sexual function index that help us to measure all the different dimensions: desire, arousal, lubrication, organs, satisfaction, and pain. Please focus on this analysis we did. When we consider sexual dysfunction overall during postmenopause, we observe that there is a real strong modulation of androgen, because dehydroepiandrosterone sulfate, that you know very well is the reservoir of all the androgen we have in the body, it's quite stable, you can measure very easily and is reliable, was strongly related to the occurrence of sexual dysfunction. Also, estradiol was a bit related, and the only variable that we were able to demonstrate that was associated during early postmenopause to sexual dysfunction in our sample was state anxiety, meaning that women, they have anxiety to perform sexuality at the time of postmenopause. This is very interesting because it confirms us that hormones are important, but also the attitude of women is important. Because if you think about, if I consider the sexual response as a circle, if I'm expecting to have some kind of sexual pain, sooner or later I will develop a vicious negative circle. And therefore, even my libido will be affected. So this concept is very important because it brings our attention to the fact that if we address a very simple symptom, such as low lubrication and pain during sexual intercourse, we can improve other aspects of the sexual response. Of course, maybe some women, they will have drive, sexual drive as the most important symptom, but sooner or later they will develop pain as well. So in our practice, we really need to understand which one is the leader symptom. Think about if the leader symptom is dyspareunia. Sooner or later, you will develop the negative circle. You will develop, for example, hypertonic pelvic floor. So if you will use a treatment to address the atrophy, maybe you will not resolve the symptom because you have also to work on other dimensions, even to work on pelvic floor. If the woman, she is anxious, you have to work on anxiety. So this is the reason why sometimes it's not so easy to treat our patient, especially if these women, they suffer from the disorder since a long time. And this is the reason why we really need to address very early that condition. The condition you know very well, we talk a lot into meetings. Now we consider all the symptoms around the pelvic floor, so we don't name a vulvovaginal atrophy, this condition anymore. We name a genitourinary syndrome of menopause. And symptoms are not only in the vagina. This is very important. It's not only vaginal atrophy, but is the atrophy of the entire system, so the vulva and the urethra. And this is the reason why now we really need to consider the role of estrogen and androgen for urogenital health. We know that estrogen are essential, and this is the reason why we have low estrogen. We develop a change in the anatomy and the function of the vagina. We know that we reduce the epithelial thickness, that we modify the proliferation of connective tissue, reducing the elastin and the collagen of the tissue. And very interestingly, nowadays, we study a lot more the microbiota. And the microbiota issue is very fancy, and it's very interesting because we have seen that women, they have an alteration of the microbiota, they report more symptoms. Every woman has alteration of the microbiota. We know that since many years from this cartoon. But very recently, we know that some women, they have a significant more alteration of this microbiota. And this is what we name, you remember the old term, atrophic vaginitis, meaning that you have the inflammation. This is something completely different from vaginal atrophy, to have a pale vagina, as you see in there. In some women, you have the inflammation, and this will make a big difference in the way we treat our patient. Because for some women, maybe estrogen, they can be enough. For others, you really need to restore also the microbiota, because this is something that you will see will be extremely relevant in research for the next few years. But as I told you, it's not only an estrogen story. We know that androgen, they play a role on the genital tissue. And the genital, they are affected. They are the vagina, especially the muscular layer that is affected by androgen. But keep in mind that all the machinery of the vulva is strongly affected by androgen. Not only testosterone, but the precursors, because now we know that it's not only a question of circulating level, because I'm sure you know that it's very difficult to relate really some sexual dysfunction to testosterone. It's almost impossible, because it's very difficult to have a reliable methodology. Whereas, as I've shown you before, sometimes you may make a connection between the HEA, the HAS, and sexual symptomatology. This is really because this androgen is so important and is metabolized within the tissue with the concept of intracrinology that may affect the machinery of the sexual response. And you see here, this is a very famous cartoon that was produced by a very good friend of mine, Abdul Tresh, in the United States, in Boston, in which he was able to demonstrate very well that the story is not only to have a dry vagina, okay, but it's really that all the hormones, they affect a different level, the epithelium, the lamina propria, the muscularis, the process that give origin to the orgasmic platform. And so that we have a lubrication in the vagina. This is spontaneous lubrication. This is vaginal dryness. But women, sometimes they do not produce enough lubricant. That is the result of a neurogenic secretion that is mediated by the peripheral nervous system driven by the central nervous system. And you recognize here all the different mediators I have reported before. They are able to affect the blood flow and the muscular and neuromuscular response that is responsible for orgasm. Of course, in the practice, we give a suggestion to diagnose the condition. And you know which one are the most common way to diagnose the condition. First of all, asking about the genital symptoms, not only dryness, but also burning and irritation, because you can check about the inflammation. Then we ask about sexual symptoms, lack of lubrication, discomfort or pain, impaired function, and you ask about urinary symptoms, urgency, dysuria, recurrent urinary infection. You have to pay attention because you have to exclude other conditions, for example, autoimmune disorder, lichen sclerosis. You have to exclude hypertonic pelvic floor, and you have to do very simple things to try to support your subjective reporting of the symptom. And the most common objective signs, as you know very well, it's a higher pH, so less acidic, and maybe doing a vaginal smear in which you can demonstrate the number of superficial cells. And this number, 5%, is very important because it's important to remember that all the different new drugs that we put on the market to demonstrate they are effective for VVA or genitourinary syndrome of menopause, they should include the patient they have less than 5% of these cells. So when we want to objectify the condition, we really need to use this tool. Then, to finish the first part of my talk, I want to report your attention on some new data we have from other survey, most recent than the Viva and the Closer my friend was alluding before. They try to understand better the involvement of VVA and GSM for quality of life of women, but also they try to put the attention on the fact that if you treat VVA, you can also improve sex drive in the majority of women. Because you see that in this survey, Revive, we were able to demonstrate in different countries in Europe, because remember, I always focus my attention on the social cultural issue. We should collect data in every country of Europe and compare, for example, to Turkey. Why? Because it's different in different contexts. And you see that women with a partner, women without a partner, if they have a diagnosis of VVA, they report less sex drive. So as I told you, low sex drive may be reactive to dyspareunia. But we know that more or less 20% of women, they start their entering menopause already saying, I have low desire. And these women, they are completely different, because maybe they have low desire, they report pain, but you're not able to demonstrate a VVA. Why? Because they have another disorder that is driven by low androgen insufficiency syndrome. We know that women, when they enter their 40s, as I told you, they can report in the office some symptoms. Low motivation, low sex fantasy, low enjoyment, low arousal, less sensation in the genital. And also these women, maybe they still have their menstruation, but they start reporting some premenopausal symptoms, maybe some vasomotor symptoms, insomnia, like they are having a severe premenstrual disorder, premenstrual syndrome, for example. There are these women, they maybe start losing bone mineral density, they start losing muscle mass, they lose the pubic hair, and they report poor quality of life. These women, they are completely different. Of course, they can be menopausal women, they had surgery, they had a premature menopause, but sometimes they are premenopausal women. And so we really need to recognize this cluster of symptoms in order to protect our patient. You see here, this problem is named hypoactive sexual desire disorder. And hypoactive sexual desire disorder can occur in premenopausal women and in postmenopausal women. Sometimes it's even more reported in premenopausal women. So you understand easily that something is going on in some patients. Maybe they are more sensitive to androgen deficiency, but for other women, this problem is related to relationship, to overstress, to depression, to other conditions. So our ability to recognize these women will be very precious in the office, because it will help us to motivate women long before entering the menopause to do something to their own sexuality. You see that the symptom is quite frequent, because hypoactive sexual desire disorder does not mean only having low desire, but keep in mind reporting the distress. And you see that what I've told you is true. Being in a partnership, being depressed, even having anxiety, and keep in mind urinary incontinence, because women, they don't feel good, they feel unease to enter sexual intercourse with their partner because of urinary incontinence. And this has nothing to do with VVA. It's something that is before, is related to the desire. And keep in mind as well that these women, sometimes they take hormone medication, and the top medication that is involved in this is combined hormonal contraception. Some women, they entering the menopause, maybe during the transition with hormone, such as a combined hormonal contraception, they can report this symptom as a result of low androgen availability. So we have always to keep in mind that there is something that is related to hormones and something that is related to other aspects. And of course, we are OBGYN. We focus on helping women to relieve condition, but we have always to be well balanced and to understand when maybe even the help of the psychotherapist is important. Now, in the second part, I want to focus more on the consequence on quality of life and management. The most important concept with GSM, VVA, and these sexual symptoms is they are chronic. They will not go away. But also we have to remember the impact on the woman, because I'm sure that you have in the office women, they don't have so much VVA and they are highly distressed from vaginal dryness and sexual symptoms, poor lubrication, low orgasm, poor arousal. And other women, they have a severe disease and they say, okay, I'm just fine. You know, my sex is fine. So we really need to be able to understand the impact on the woman's life, because if we do not understand the impact, these women, they will not be motivated to be treated really. You see, the impact is very strong on the sexual domain, satisfaction, spontaneity, intimacy, relation with their partner. So women enter a vicious emotional circuitry, but also keep in mind that other dimensions of social life are affected, and even quality of life, enjoyment of life. And to reinforce this concept, I want to share with you the results of one of my recent studies I conducted with a couple of friends, Santiago Palacios in Spain, Nick Panet in the UK, in which we try to understand better the relationship between subjective symptomatology, objective symptomatology, and the impact on quality of life and well-being. The difference in this study, in comparison to study I conducted in the past, it's really that we put together what women report. You see at least one VVA symptom, and the two most important were dryness and dyspareunia, and what we see with our eyes when we do the consultation. So when we confirm VVA with a scale, the vulvovaginal health index, which include the characteristics I have described to you before, higher pH, pale vagina or an inflamed vagina, and so on. You see that in the general office of the OBGYN in a menopause clinic, these symptoms, they are pandemic, because it's not the 50% we report in the survey. It's really up to 90% of women, they report dryness and pain with intercourse. And then you have also so many other symptoms we have to see. And you see that when you combine subjective symptom with objective symptom, the presence of the symptom is really extremely high and relevant. So the first point is really that when you have the condition, you really have to treat this condition. Why? Because the impact on quality of life is enormous. you see, we consider 3 different scales of quality of life. The general one, which is the EQ5DL, and we consider a new scale to measure quality of life related to vaginal atrophy and sexual problem at menopause, the so-called DIVA score. I will show you some subscale in a minute. You see in any case that all the different domains, but especially the quality of life associated with VVA was significantly impaired. Then severe symptom, the impairment is extremely high, and here you see urinary symptom and vaginal symptoms are the one more than vaginal symptom. They impair the quality of life of women. So we really need to focus, to move the focus from the vagina to the vulva and to the urethra, really to treat our patient. You see in this study, we confirm again that there was an impairment of sexual function, all the different domains. And the impairment was present both in women in which was not confirmed the VVA, but it was significantly higher in women in which VVA was confirmed. And also the distress associated to the condition was significantly higher. And this is also related to the severity of the symptom. Why I'm telling you this? Because we realize that we are not good enough in treating our patient. Why? Because when we NICPANE, we did a sub-analysis of the women that were treated and the ones that were not treated for VVA, we discovered something amazing, that the women that were treated, they were the one more symptomatic in every domain. You see here all the symptoms, and you see here even better, that only women, they are severely affected, they are treated. What's the meaning? We know the treatment is effective. The meaning is that we delay the treatment to our women because we treat the condition only when the condition is severe and say hello to you. We do not prevent. We really need to treat the condition when it's mild, when the woman is reporting. But you know, sometimes women, they do not report. Also because, and this is true as well, even for hypoactive sexual desire disorder, because when women, they already develop a lack of self-esteem, less femininity, they feel very concerned about their relationship. Ladies and gentlemen, for sure, these women, they will be extremely difficult to be treated. And indeed, you see that women, when they report the distress associated also to low desire, they are highly symptomatic for other domains. The situation on quality of life and hypoactive sexual desire disorder is even worse because, as you know very well, we don't have so many labeled treatment to restore the hormonal environment of women with hypoactive sexual desire disorder. So the impact is enormous. And many women in the postmenopause, we don't have so much time left, but believe me, they want to do something for themselves. So which one are the strategies to maintain sexuality in the menopause? I believe that apart from giving general information about, that you should be aware that this is happening throughout life, with the aging process, it's our duty to recognize signs and symptoms of VVA and hypoactive sexual desire disorder, making an appropriate diagnosis. And of course, then we really need to pay attention to the partner, promote the health. We can propose a treatment, but remember that we have to do in a timely fashion. Otherwise, for sure, women, they will be very much affected. The most important symptom, remember, is pH, subjective dryness, and of course, if you recognize objective symptom, maybe you can motivate the woman, but it can be late. And what we have to do, we have a lot of strategies out there This is one of the many review of the literature we perform in Europe. And what is essential is to tailor the right treatment to the right woman, depending on many factors, so a risk-benefit balance, but also depending what you want to obtain. Because, of course, if you have a general menopausal syndrome, you should propose maybe systemic hormone, especially those that have data out there demonstrating particular efficacy on sexual function and dysfunction, for example, tibolone. But you have also to propose specific treatment for VVA, vaginal dryness, because we know that VVA is the most important component of sexual dysfunction during the menopause. Of course, we can propose also other treatment. We don't have the time to go throughout that. Very famous and important laser, radiofrequency, but we are still expecting long-term data and even alternative treatment. Just a few words, pearl of practice. Which one is the best hormonal treatment for women? Systemic. Every treatment can help. But for sure, we have data out there suggesting that transdermal route of administration can be a little bit better in comparison, for example, with conjugated equine estrogen. Why is this? Because, as you know probably very well, transdermal estradiol respect the androgen environment, so lower androgen less. Tibolone, I told you already, we have plenty of literature out there suggesting that tibolone is a special kind of HRT because it combines estrogenic and androgenic effect due to one of its metabolisms, that is an androgen, but also because tibolone is able to modulate the adrenal steroidogenesis and so is able to improve the availability of testosterone and DHEA, and also is capable of lowering a little bit sex hormone binding globulin, therefore making androgen more available. Then we have treatment for GSM. We know first-line treatment, lubricant, moisturizers, but low dose vaginal estrogen, vaginal DHEA, or Spemifen we have in our country. I'm not sure you have in Turkey, but they can be good drug. Why? Because they target the symptom of VVA. What we know out there from the literature, that vaginal estrogen have different doses and they can be used safely and more or less all the treatment are equal. We have cream, we have suppositories, we have tablets, we have even the ring, we have the gel, depending on the market. And they can do some good to the symptom. You see the guideline, the IMS guideline, they say they may be equally effective. Why I want to put this slide? Because this slide in the IMS guideline, we overcome the idea that you cannot combine local treatment with a systemic low dose. So, of course, if you have only VVA and dryness and dyspareunia, you can treat only locally, but remember that there is no contraindication to make a combination of the two drugs. And remember that when you treat with an effective drug, you improve the quality of life of our patient. This is the Closer survey that I know that you like very much because it was the first study ever that analyzed what men think about having a treatment for their partner. And you see that men, they are more happy to see the woman in their relationship. They feel that the woman is more satisfied with sexuality. So even low estrogen therapy in the vagina can do a lot of good. But as you know, there are some women, they have contraindications, so they cannot use that. And this is the reason why we developed more recently, 2 minutes I'm finished, treatment, they can target only the receptor, So only the receptor you have in the vagina. It's a SERM, we name it spermifene, 60 milligram. It has been demonstrated extremely effective in relieving vaginal atrophy and dyspareunia. Then I told you nowadays in some market, I don't know if you have in your market, we have even the HGH. So it's behaving like local estrogen, but is acting directly into the tissue, is transformed in testosterone and estradiol, and has been demonstrated as effective as local estrogen on all the endpoints we use to measure the effectiveness on VVA. And last information I was to share with you, the complexity of treating hypoactive sexual desire disorder. We should do a very comprehensive story, but it's important I tell you that you have a screener in your practice. So if you recognize that women, they have hypoactive sexual desire disorder, you can do something to them. Of course, you have to relieve menopausal symptoms, you have to relieve the pain, because you see that hypoactive sexual desire disorder is strongly comorbid, as I told you, with VVA. But if you recognize that this condition in the menopause, look at this part of the slide, is related to low androgen, you should treat with androgen. We have also some kind of CNS agent, but we don't have the time to talk about that. They are not labeled in the menopause. We are labeled these agents only in premenopause. The name is plibanserin, bremelanotide. We hope we will have on the market also for the postmenopausal women. At present moment, we have only testosterone therapy, but as you know very well, it's not available in every country. We don't have a label treatment for postmenopausal women. We hope we can have again on the market testosterone, because you see, is the one that has a level of evidence 1 in postmenopausal women. And we have many products on the market, but we have to use off-label the gel for the male. The dose is 300 milligrams. We had these patches in the past, and we were able to demonstrate without any doubt that it can be extremely effective on desire and distress, improving many aspects of the sexual response. And this treatment is safe. There was a wonderful meta-analysis, and I want to end my talk by saying that in the global position statement of the IMS and of the International Menopause Society, now we really believe that we should use more testosterone for our patient at the appropriate dose, and probably we can use also in the late reproductive years when we able to demonstrate hypoactive sexual desire disorder. And with this, I thank you very much for your attention. Probably I was a little bit long. Sorry about that. I invite you all to Lisbon at the next IMS meeting. Thanks a lot for your attention.
Doktor Nappi'ye çok teşekkür ediyoruz. Çok verimli bir lecture oldu bizim için. Ve şunu fark ettim, Tamer sen de fark etmişsindir herhalde. 20 yıldır aşağı yukarı izlerim Doktor Nappi'yi. Fakat her seferinde farklı şekilde yorumluyor ve farklı slaytlarla anlatıyor. Bu da izleyiciye olan saygısını gösteriyor benim anladığım kadarıyla. Çünkü aynı şeyler olsa bile çok çok farklı görüyorum. Ben aynı sunumunu 2 defa dinlemedim şimdiye kadar. 20 kere belki dinledim, çok yerde konuştuğu için. Ama onun için özellikle tekrar teşekkür ediyoruz. Efendim şimdi bu toplantının sponsorlarından Ortogen firmasının fitoöstrojenlerle ilgili bir sunumu olacak. Onu izleyeceğiz kısaca. Onun için Doktor Fatih Bey'i davet ediyorum konuşması için.
Saygıdeğer hocalarım, değerli meslektaşlarım, herkese iyi akşamlar. İsmim Fatih, İstanbul Başakşehir Çam ve Sakura Şehir Hastanesi'nde kadın doğum uzmanı olarak çalışmaktayım. Aynı zamanda Türkiye Menopoz ve Osteoporoz Derneği'nde aktif görev almaktayım. Bugün menopozda fitoöstrojen tedavisiyle alakalı sizlere kısa bir sunum yapmak istemekteyim. Öncelikle sunumumda şu 3 soruya cevap vermem gerektiğini düşünüyorum. Birincisi, menopozda bir tedaviye gerçekten ihtiyacımız var mı? İkincisi, menopozda mevcut tedavi yeterli mi, değil mi? Ve son olarak da menopozda neden fitoöstrojen diye bir konsept şu an gündemde. Hepimizin bildiği gibi perimenopozal dönemde hastalarımız bazı semptomlar yaşamakta. Bunlar içerisinde en sık görülen sıcak basması ve bunun da insidansı %80'lere kadar ulaşmakta. Bu hasta grubunun yaklaşık 1/3'ü tıbbi yardım için kliniğe başvurmakta. Dolayısıyla evet, bazı hastalarda gerçekten bir tedaviye ihtiyacımız var. Hormon replasman tedavisi mevcut en etkili tedavi. Ancak 2002 yılında yayınlanan WHO çalışması sonrasında kullanımı ciddi oranda azalmış vaziyette. Şöyle bir örnek verilebilir. 2001 yılında kliniğe başvuran her 5 hastadan bir tanesi hormon replasman tedavisi adayıyken bu durum 2015 yılında her 25 hastadan birine kadar düşmüş vaziyette. Her ne kadar bu çalışmadan sonra yapılan eleştiri yazılarında ve subgrup analizlerinde hedef popülasyona atfedilen riskin çok da yüksek olmadığı dile getirilse de bu durum çalışmanın yarattığı etkiyi maalesef yaratamamıştır ve günümüzde hala WHO çalışmasının heretik kullanımı üzerindeki olumsuz etkisi devam etmektedir. Ek olarak hormon replasman tedavisinde preparat seçimi, uygulama yolu, doz ve süre gibi farklılıklar olması klinisyenler açısından sorun teşkil etmektedir. Dolayısıyla şunu söylenebilir, hormon replasman tedavisi evet etkilidir, evet yeterlidir ancak klinisyenler ve araştırmacılar bu tedaviye alternatif yöntemler araştırmaktadır. Peki neden menopozda fitoöstrojen kullanımı diye bir konsept var? Aslında bu çok yeni bir kavram değil. PubMed'e bakarsak eğer yazılan ilk yazıların yaklaşık 40 sene önce yazıldığını görüyoruz. Burada temelde bu konseptin ortaya çıkması bir gözleme dayanıyor. O da şu, sıcak basması insidansı Doğu toplumlarında, Japonya'da, Çin'de yaklaşık %15 civarındayken bu insidans Batı'da, Avrupa'da, Amerika'da %80 ve hatta %85'lere kadar ulaşmakta. Bu farklılık klinisyenlerin ve araştırmacıların dikkatini çekiyor. Bu durumu genetik, sosyal yaşam ve veya beslenmeyle ilişkilendirmek istiyorlar ve akabinde menopoz tedavisinde beslenmenin ve bitkisel kaynakların önemi ortaya çıkmış oluyor. Uzak Doğu toplumlarında soya tüketimi oldukça fazla ve bu batıya nazaran kat ve kat fazla. Soyanın içerisinde saptanan bazı bileşenlerin östrojene benzer etki ettiğini saptanmasıyla beraber menopozda östrojen, bitkisel kaynaklı östrojen tedavisi literatüre kazandırılmış oluyor. Peki nedir bu fitoöstrojenler? İsminin anlaşılacağı gibi aslında bitkisel kaynaklı östrojen benzeri bileşiklerdir. Östrojen reseptörüne bağlanma özellikleri vardır. In vitro olarak gösterilmiş protein tirozin kinaz inhibisyonu, DNA topoizomaz inhibisyonu ve antioksidan özellikleri vardır. Ek olarak dokudaki östrojen miktarına göre agonist ve veya antagonist etkiler gösterebilmektedirler. Fitoöstrojenleri östrojenden ayıran en temel farklılık reseptör düzeyinde. Bildiğimiz gibi östrojen reseptörleri alfa ve beta olmak üzere temelde ikiye ayrılmakta. Bunlar içerisinde alfa reseptör çok daha potent, uterus ve memede baskın reseptör, beta ise etki açısından daha zayıf, kemik ve beyinde baskın reseptör. Fitoöstrojenler selektif olarak beta reseptörüne daha fazla bağlanmaya meyilliler. Bu bize iki şey sunuyor. Birincisi daha az bir potansi ancak uterus ve memede yani yan etki görmek istemediğimiz dokularda daha az etki varken kemik ve beyin gibi bizim asıl etki görmek istediğimiz hedef dokularda daha yüksek bir etki. Peki fitoöstrojenler gerçekten etkili mi? Bununla alakalı sizlere birkaç tane meta-analiz göstermek istiyorum. İlki JAMA'da 2016 yılında yayınlanan fitoöstrojenlerin menopozal semptomları gidermedeki etkisini irdeleyen bir meta-analiz. Tabloda göreceğiniz gibi plasebo ile kıyaslandığında fitoöstrojenler anlamlı düzeyde etkili saptanmış. Bu bulguyu doğrular nitelikte bir başka çalışma daha yapılıyor. Climatic dergisinde bu da 2015 yılında yayınlanan bir meta-analiz. Yine aynı şekilde plasebo'ya kıyasla fitoöstrojen tedavisinin anlamlı ölçüde etkili olduğu saptanıyor. Dolayısıyla fitoöstrojenlerin etkili olduğunu bu iki çalışmanın özetinde söyleyebiliriz. Peki bu fitoöstrojen kullanımında bizi nasıl yan etkiler bekliyor? Bir önceki slaytta gösterdiğim metanezde kısa dönem yan etkiler diye irdelenmiş ve plasebo'ya kıyasla kısa dönem yan etki açısından plasebo ve fitoöstrojen arasında herhangi bir farklılık saptanmamış. Maturitas'la yayınlanan bir başka derlemede bu yan etkiler tek tek irdelenmiş. Bakacak olursak aslında birçok ilaçta, birçok tedavide, birçok preparatta gördüğümüz non-spesifik yan etkiler bunlar. Gastrointestinal rahatsızlık hissiyatı, kilo alımı, memede hassasiyet gibi non-spesifik sorunlar. Son olarak bu senenin başında Climacteric dergisinde yayınlanmış bir review'dan bahsetmek istiyorum. Bu review'da aslında güncel olarak menopozdaki fitoöstrojen tedavisinin neye tekabül ettiği kısaca özetlenmiş. Eve götürülecek 3 mesajla bunu özetlemek isterim. Birincisi, menopozda fitoöstrojen kullanımı menopozal vazomotor semptomların giderilmesinde az ve yavaş etkili olsa da etkili gözükmekte. İkincisi, fitoöstrojen kullanımı kemik sağlığı ve kardiyovasküler sağlık açısından faydalı gözükmekte. Ve üçüncüsü, yine fitoöstrojen kullanımı meme kanseri, endometriyal kanser, kolorektal kanser açısından risk artışı yapmaz iken koruyucu özelliklere de sahip olabilmekte. Özetle menopozda fitoöstrojen kullanımı HRT'ye alternatif bitkisel tedaviler içerisinde yaygın ve etkili gibi durmakta. Hasta uyumunun yüksek olduğu bu tedavi seçeneğinde göreceli olarak yan etki de daha az görülmekte. Şu söylenebilir ki seçilmiş hasta grubunda da kullanılması uygun olmakta. Bu güzel platformda bana sunum şansı veren değerli hocalarıma çok teşekkür ederim. Sizlere de iyi akşamlar diliyorum.
Okay. Evet, değerli bizi izleyenler, bu saate kadar şahane 2 tane konuşmayı Rossella Nappi'den ve çok güzel bir fitoöstrojenlerle ilgili de Fatih'ten bilgi aldık. Şimdi ben hemen fitoöstrojenler konusunda Rossella Nappi'nin ne düşündüğünü öğrenmek istiyorum. Dear Rossella, what do you think about the phytoestrogen, the impact on quality of life and sexual function? What is your opinion and experience?
I thank you for your question. As you know, they are not included in guideline in sexual medicine in the menopause. But my experience, and also if we think about some studies that are out there, maybe in small sample, not always they are randomized, double-blind, placebo-controlled trial. But if you improve the quality of life of your patient, if women that feel better, they have less hot flashes, as you know very well, they are extremely effective on insomnia, for example, sometimes. They can help you mood and fatigue, and therefore you will improve also sexual function. There are some data also suggesting that you may improve the karyopyknotic index, so the number of superficial cells you are in the vagina, you can improve the pH. So I'm sure that we have to study more. As you know, not every woman metabolized, unfortunately, phytoestrogen in the same way. And this is also one of the reasons why sometimes the results, they are not all concordant. But since can be a first line for women with mild, moderate symptoms, they cannot take hormones, or they are averse to hormone, because unfortunately women, they are averse. We recently published in April a study in which we compare how many women they are averse to hormones in the United States, in Europe, and in Japan. And it's amazing to see that women, they are extremely averse to hormone because they believe it's not natural to treat menopause, unfortunately. And so this is the reason why we should find any strategy that improve quality of life and well-being. And so phytoestrogen are welcome if we can do something good to our patient. And keep in mind that for sexual medicine, low estrogen therapy locally they can be extremely powerful. I've tried to show you this, that this is the first sexual act we can do to a patient. You don't need to be a sexologist to improve sexuality of your patient. If you improve their quality of life in general, lifestyle, exercise, phytoestrogen, then for some women, they are really desperate. You use systemic estrogen, systemic androgen. And you can use local estrogen therapy, any kind, and they will work very well.
Thank you. Thank you. Başka soru var mı? If you have any other question.
Var. Ben sorabilirim şimdi. Thank you very much, Nappi, for your fruitful lecture. I always keep your study about 20 years. Every time you have the changing the slides and the style of the lecture, but the basic is the same. Congratulations for this one. Thank you very much again.
Thank you, dear. You know, I started many years ago studying sexuality, and therefore, you know, every day I try to add a little piece of information to try to develop the field, to understand better what's going on, and I always try to show you the story, because so many doctors, they still don't value sexual medicine, you know, and this is the reason why we should do a lot of information about this topic. I remember I came to a urological big meeting that was in Istanbul so many years ago, and I gave a lecture on female sexuality, and I was on TV in Turkey, and it was fantastic, because we need really to do more for our patient, you know, and this is something really welcome. So thank you for the invitation.
Thank you again. I would like to ask in Turkish, Tamer is translate for you for the Turkish speak lectures. Şimdi low dose östrojen için yani low dose terapi yaptığımız oral tedavi alan bir insan için bu vajinal kuruluk vesaire bu seksüel problemleri çözmek için lokal östrojen yeterli mi sadece?
One audience is asking Rossella, the low dose vaginal estrogen is sufficient to treat the symptoms, vulvovaginal symptoms. Sometimes some woman needs more estrogen by administering the systemic route. What do you think about that?
You are absolutely right. As you know, the story of very low dose is a crazy story that comes following the WHI. Following the WHI, we decided we should go lower, okay? And I absolutely agree with you that when women, they have very severe symptoms, you have seen from the study we published last year, if you give low dose estrogen, of course, women, they still have sometimes the symptom. So we should treat very early if we want to use low dose, because in my experience, if you treat at the very beginning of the menopause trajectory, you can prevent female sexual dysfunction. Whereas if you have a very old vagina, 60 years old, very severe, if you use a 0.03 or you use a 10 microgram or you use a very low estrogen such as estriol low dose, maybe is not enough to reverse the condition. This is the reason why in some cases, if you really want to treat the sexual dysfunction, you really need to go systemic. Or remember this new drug we have in Italy and Spain, for example, Stamifene, very selective, is very acting on the tissue from the inside, and it's very useful. Also, the HEA in the vagina is very powerful, even though it's low dose, because it's transformed in several metabolites. They can be active not only on the epithelium, but on the vascular, muscular, and neuromuscular response. So we really need to tailor the right treatment to the right woman. But you're absolutely right that sometimes when you want to reverse a symptom, you should give systemic. I use a lot of Tibolone in my office. I use a lot of transdermal, natural progesterone, and off-label testosterone. But only a minority of women, as you know very well, they are motivated to do this treatment.
Tamer, çok enteresan, güzel bir sual var şimdi Doktor Nappi için. Şimdi soru şu, artificial menopoz yahut da bu özellikle meme kanserinde oluşan, yaratılan menopozla normal menopoza giren kadındaki seksüel disfonksiyonu aynı kategoride kullanabilir miyiz? Yani ikisi birbirinden farklı mı yaklaşımımız, aynı mı olmalıdır?
The other question is directing you is the woman with breast cancer, operated breast cancer. Is your management different? Is your management different from the other woman, or what kind of management you choose?
Yeah, this is a very good question. We need a seminary of 90 minutes to address everything. I didn't include them, I'm sorry. But you know, these women, we have data suggesting that they report more or less the same VVA of women without breast cancer. With, as you know, aromatase inhibitors, the situation is horrible in comparison to women that are on tamoxifen. And as you know, systemic hormones are contraindicated. We, according to the guideline, we always say that women on tamoxifen, they can use a very, very low dose local estrogen, talking to the oncologist. And I have to tell you that now oncologists, they are a little bit more open. Remember that these women, we use, of course, a lot of moisturizers. We are doing a lot of laser and radiofrequency to try to improve. There are a beautiful study from a Canadian woman that she was doing pelvic floor exercise, very intensive program. I have started in my department and results are fantastic because you motivate women to do the exercise. And if you do at the very beginning, in primary prevention, so you know that if you have a breast cancer patient, you put her on aromatase inhibitors, she will develop the symptom. And so you do rehabilitation, oncological rehabilitation, not only from a psychological point of view, because I'm sure that in your breast unit in Turkey, you have the psychologist, but you don't have the physiotherapist. The physiotherapist is extremely important. We don't have to use the physiotherapist only to rehabilitate in the arm when we do massive surgery. We really need to instruct maybe with nurses, midwife. They can have some expertise in pelvic floor. It's fantastic because women, they do a lot because they know they cannot do other things. And so they gain more confidence with their own body. They do a lot of foreplay with their partner. And this is very rewarding because remember that if you fantasize, if you use your body, sexual function is a function. And so it's a function of the vagina, it's a function of the tissue. And so if you exercise the vagina, you can do a lot of good. So we really need to go on doing studies like this. This woman, she published against the low estrogen therapy. And this is extremely relevant to me, non-pharmacological treatment for these women. It's also important you keep in mind that if you have the passport in your pocket that you overcome the cancer, following 5 years, 7 years, 10 years, you can go on with some treatment, local estrogen for sure, and ospemifene. In Europe, we have this data. in mind as well that these women, sometimes there are some data out there suggesting that local androgen therapy can be good, because if you are on aromatase inhibitors, you can even stimulate some androgen receptor, and you can do some good. Of course, it's just 1-2 studies. You really need to have a strong connection with your oncologist. And for selected cases, I prepare some testosterone cream. I use also some phytoandrogen to put in the vagina to try to improve their condition. And sometimes they work. And so we really need to open our mind to new stuff, and also to sexual training for these women, to go back to normal. It will take time, but it's fun. It's a lot of fun with this patient.
Thank you. Birçok soru da özellikle Rossella Nappi'nin testosteron off-label kullanımını merak ediyorlar. Onu izninizle sormak istiyorum. Dear Rossella, many of our audience are curious about your off-label testosterone usage. So can you give some clues about that?
I try to use the gel.
Sorry to interrupt you. We don't have female testosterone. Testosterone in female doses, but
we don't have.
What is your
I always use the dose that was published, because working in a university hospital, I always stick to the 300 microgram daily. So I use testosterone gel, because the one for male, and I try to calculate, the amount of gel I need. And I trust my patient, of course, because I always tell them, listen, you don't have to exaggerate, because I have to tell you that women that feel better, and so sometimes they use more. And so this is something a little bit unfair, because I always say, listen, you don't have to go too much higher. So in my experience, if I select the right patient, the one she has hypoactive sexual desire disorder, the one she has poor arousal and congestion, I can obtain beautiful results. Usually following 3-6 months, I measure anyway total testosterone, because I learn a lot from andrologists, because they are very good friends of mine. I learn sexual medicine from andrologists. You have in Turkey one of the biggest. I think it was extremely good. And when we were together in Ipswich, and always they were teaching us how to use androgen. I use also the HEA orally. I made some of this preparation, and I believe that the HEA may be effective. As you know, the literature does not support the use of systemic DHEA, unfortunately. But because it's like phytoestrogen, in my opinion, it depends how the woman metabolite the amount of DHEA that you are prescribing. And also, in my opinion, if you use the HEA systemically, you should use the tissue. So if you use the HEA for the brain, you should learn new things. If you use the HEA for the muscle, you should exercise. If you use the HEA for sex, you should do some sex, at least, masturbation and foreplay with your partner, because the drug is active. This is my personal experience. So we are in a webinar. This is pearl of practice. It's not, I will never say something in a congress, really, but this is what I observe, and we should publish some of this observational data. Because, women really, if you give the HEA and women, they don't exercise, the muscle, they will stay there. But if women, they exercise, they will change their body shape. And so, androgen, they are important, in my opinion. But they are understudied in women.
Thank you so much. Başka soru var mı Sezai Hocam size gelen?
Var. Mesela bu klasik bir sual. Bu eskiden beri tartışılan bir şey. Zannediyorum Nappi'nin de bu konuda tecrübesi vardır diye düşünüyorum. Çünkü olay vazokonjesyon ve lubrikasyon olduğu için bunu artırmak için sildenafil yani Viagra kadınlarda ne gibi bir etki sağlıyor acaba?
Another question is you look you understand.
I think I understand. You are asking me if we can use for a subset of women PD5 inhibitors, okay, such as Viagra or the brothers. Okay.
What is your comment?
My comment is that I always trust the data, you know, because I'm a scientist. So I tried in diabetic women and it works. I tried in women with SSRI-induced sexual dysfunction and it works. The problem, in my opinion, that really PD5 inhibitors, I am an endocrinologist, so I believe that hormones, they drive the show. And so I believe the data suggesting that if you have enough testosterone for men, these drugs, they work better. And for women, this is the issue, that if I have a premenopausal woman, she's diabetic, diabetes 1, and I prescribe sildenafil, is working very well because she's estrogenized and probably she has some androgen. If I use in a postmenopausal woman, I don't see so much difference. But remember, it's completely different. The way the woman feels the organ is different from male. Women, they really, for some women, there is a relational component, there is an intimacy component, and this component is stronger than feeling a little bit hot down there, you know. And some women, they don't enter the sexual intercourse just because of feeling that burning down there. But, for example, another group of women I tried, I never published this because my hospital, you have to consider that I'm doing so much sexual medicine, but my hospital is very strict in allowing me protocol, and therefore I cannot do a proper study. So it's just off-label, and it's very difficult for me to publish. But hysterectomized women, exactly like male, they are prostatectomized, can benefit from a very low dose of PD5 inhibitors on the long run. There is a subgroup of women, they don't feel orgasm anymore following surgery. As you know, this is a slippery floor because no gynecologist wanna say to their patient, if I remove your uterus, you will have an impairment of sexual function. Because as you know very well, if a woman, she has fibroids, she has menorrhagia, she will improve her sexuality because she will feel better. But in some women, when you remove the uterus, and also it's even worse when you remove the ovaries because you don't have testosterone anymore, and you cut, especially when you have cancer, is horrible. And so for these women, sildenafil can work because it will reinnervate the upper part of the vagina. But it's really women, they are very motivated women, they are open-minded, high level of education. And so, you know, we cannot generalize this. But I'm sure that we should study more. And probably in the future, as you know very well, we are studying a combination of androgen with sildenafil. And data are very beautiful. But since it's so difficult to put on the market, think about flibanserin is only in Canada and US. Bremelanotide is only in the US. It's so difficult to motivate women to be on a treatment for sexual function. So we really need to have a treatment one shot like the one males have, and maybe women, they will take more, because to take a tablet every day to solve a problem, it's not so easy in sexual medicine. This is also another story.
Thank you, thank you. Şimdi toparlayacak olursak aşağı yukarı, demek ki sildenafili Rossella daha çok histerektomize olmuş bir subgrup kadında iyi geleceğini söylüyor. Diyabette iyi geleceğini söylüyor. Meme kanserlilerde özellikle DHA'nin ve özellikle ostemifenin tavsiye ettiği 5-6 sene geçtikten sonra, 7 sene geçtikten sonra çok lokal olarak da östrojen kullanabiliriz dedi. Ve testosteron için de 300 mikrogramlık jellerden bahsetti ve 3 ila 6 ay kadar kullanabileceğimizi söyledi. Artık yavaş yavaş sona geliyoruz. Ben izninizle Rossella'ya bir teşekkür ettikten sonra Erdoğan hocamıza kapanış için sözü vermek istiyorum. Ne dersiniz Sezai hocam? Sizin
Tabii. Ben de aynı fikirdeyim.
Rossella, we are closing now. We make you tired so much. Thank you for your accepting our invitation. It's great honor for us, really. Thank you so much.
It was an honor for me, actually, because I have so many friends in Turkey, and you are one of them. And Erdoğan as well, and all the others. And, I always think that we have to be more together, and maybe the pandemic, you see, is an opportunity, and to stay together for 1 hour and a half. And I was very at ease. Thank you very, very much for the invitation. Bye-bye.
Thank you again. Yes.
Sevgili moderatör kardeşlerim, sevgili konuşmacılar, hepinize çok teşekkür ederim. Çok güzel bir webinar düzenlemişsiniz. First of all, I want to thank Dr. Rossella. Is here or not? Neyse. Nice speech, an excellent speech. And next year, 30th anniversary of our Turkish Menopause and Osteoporosis Society Congress. We want to see there the Rossella. Şimdi kardeşlerim bakın 6 tane webinar düzenledik. Bu 3 webinarda menopozu Sayın Sezai Hoca başta söyledi. Gayet güzel bir şekilde menopozdan bahsettik. Son 3 webinarı da genital üriner sistemi ve bu seksüel disfonksiyonları. Şimdi kardeşlerim gelecek yazdan sonra Eylül ayında tekrar webinarlarımıza başlayacağız. Bunların içinde menopoz ve osteoporoz, kardiyolojik problemler ve IVF nasıl yapılır klimakterik dönemde, bunlara ait webinarlar yapmak istiyoruz. Bu nedenle hepinizi, sizleri orada görmek istiyoruz. Yalnız ben bir şey tavsiye etmek istiyorum. Bir gelen hastalarımızda sormadığınız takdirde hiçbir şekilde seksüel konuya değinmezler. Dismenoryenin olduğunu, disparoninin olduğunu hiçbir zaman söylemezler. Böyle bir problem yokmuş gibi, doğalmış gibi kabul ediyorlar. Onun için rica ediyorum, lütfen siz bir cesaretle soruyu sorun. Nasıl oluyor, nasıl gidiyor, ağrı var mı, yok mu diye başlarsanız arkası çorap söküğü gibi tıkır tıkır gidiyor ve devam ediyor. Gerçekten çok önemli bir problem. Bunun için ben Sayın Tamer Erel'e ve Sayın Sezai Hoca'ya bu son webinar için teşekkür ediyorum. Hepinize mutlu yaz tatilleri diliyorum. Eylül'de görüşmek üzere. Sevgiler.